طيب مرحبا بكم جميعا. And I think I'm given the green light to start. Welcome all of you. I'm really delighted to be part of these educational sessions, and I'm so grateful to the organizers. So if I'm lucky, I will cover all this in this session, which is 2-hour session: pericardial diseases, cardiac masses, preoperative evaluation, aortic diseases, expectant PET, and few others, which is a heavy load a little bit, but together we can navigate this because I have selected the most important relevant points that you really need, not only for the exam, but for your day in and day out practice. The first MCQs and all the sessions are going to be kind of MCQs that's going to open the gate for a little bit of discussion about the main points. So we have 32-year-old lady. You can key your answer in the chat box. I will follow that. 32-year-old lady presented with a stabbing chest pain, which is on leaning forward. ECG upon arrival to ER is shown below. Troponin is 0.01. What is the most likely finding in echo? So based on the pain characteristic and the ECG, what is the most likely finding in echo? Small rim of pericardial effusion, thickened pericardium, plethoric IVC, global hypokinesis, none of the above. Go ahead and key your answers. I see pericardial effusion. Okay. Any different opinions? Yeah. Pericardial effusion, pericardial effusion, pericardial effusion. Good, great. Great. I expected some of you might say none of the above as normal echo. Okay, which is probably the second most common after a small rim of pericardial effusion to find none. Okay, perfectly normal echo. So the right answer is small rim of pericardial effusion. And before I tell you why, the etiology of pericarditis is idiopathic, relating to infection, uremia, acute myocardial infarction. And in acute myocardial infarction, you can have an acute pericarditis or delayed pericarditis. The acute one is due to the direct irritation from the injurious myocardium. The delayed one is sort of immune reaction akin to Dressler syndrome. It appears weeks to months after the myocardial infarction. Neoplasm, post-cardiac injury syndrome or post-cardiotomy syndrome, and it is similar to Dressler syndrome, and it has the same mechanism, connective tissue diseases and radiation. Now, pericardial effusion is found in 60 to 80%. And of those who show pericardial effusion, 80% is small, 10% is moderate, and 10% is large. In case you have anything not clear while we are discussing the points, you can stop me, okay? Otherwise, I will just keep going on. But the ECG, like you have interpreted correctly, of the global concave morphology of ST segment elevation with sagging of the PR interval, which is probably specific finding, and PR elevation. But is not always a full-blown kind of ECG like this. Sometimes it's a bit of a subtle ECG like this. You can confuse it easily with early repolarization. Second question is, a 35-year-old male has a stabbing chest pain, which increases on lying flat and mitigated by sitting and bending forward. This is clear pericarditis. Very characteristic. There is antecedent flu-like symptoms. Which of the following is true? Elevated troponin indicates acute coronary syndrome. ECG will invariably show multi-lead ST segment elevation. Echo will show large pericardial effusion. He will need colchicine for 3 months. I'm following your answers in the chat box. D, D. Good, great. So far D, none for the others. D, B, okay, B, D, okay. So the vast majority is for D and 1 for B. So the right answer is need colchicine for 3 months. You will not always find this ECG because the pericarditis is a time course process. Acutely, yes, initially you will find the ECG, but as pericarditis process goes on, you are moving from stage 1 to stage 2 to stage 3 to stage 4. So you might get your patient here or sometime even here in stage 3. So ST segment elevation invariably in pericarditis is not the right answer, okay? Remember, the diagnosis of pericarditis, you need 2 of 4. The pain with its characteristic feature we have described, the rub, the ECG, characteristic ECG finding, and new or worsening pericardial effusion. So from here, you have clinical features, ECG features, and echo features, okay? Now, if you have 2 out of 3, that's the diagnosis of acute pericarditis, then you might request biomarker troponin in particular to see if you have myopericarditis or purely pericarditis. Then the decision goes for if this is acute pericarditis, shall I admit or discharge? That depends on high-risk features, which are fever, leukocytosis, large pericardial effusion, elevated troponin, patient on anticoagulation, patient has trauma, which induced the pericarditis, and relapsing pericarditis. In this case, you admit the patient, otherwise no need for admission. Now, the treatment is basically aspirin plus aspirin or other non-steroidal. Colchicine is good to enhance the healing process and decreases the chance of relapses. Okay. Sometimes, if you can settle the diagnosis at, these features, and you still suspect it somehow, you can consider CMR. In CMR, it's going to show delayed hyperenhancement of the pericardial. Okay. Now, for relapsing pericarditis, again, you start, the first line is aspirin or non-steroidal plus minus colchicine. But if it keeps relapsing, then you consider prednisolone. See, prednisolone is not given for acute episode and not even for the first relapse. You have to have multiple relapses to start prednisolone. And you might even go up to immunosuppressive agents, okay? Absent pericardium is compatible with normal lifespan, yes or no? Yes or no? Yes, 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 yes. Okay, good. So though the pericardium might look amazing, the physiology is amazing, constriction, restriction, pericardial effusion, all of that, but the absence of pericardium isn't a serious problem and does not interfere with normal lifespan, okay? Sometimes the partial absence might even be more serious than the complete absence, which is pericardial agenesis. Partial agenesis, sometimes it can lead to herniation of that part in particular, and that might impose a problem. Okay, I have a 72-year-old male, 3 days post-cabbage, has tachycardia and hypotension, echo requested to rule out tamponade. Echo window was poor, IVC was 1.2 centimeter with more than 50% collapsibility. Which statement is true? The state of IVC as described, rules out tamponade. Localized hematoma and or hypovolemia causes tamponade without plethoric IVC. The state of the IVC has low sensitivity to rule out tamponade. The state of the IVC has high specificity to rule in tamponade. So go ahead and key your answers. Following you. C. C. Others. B. Okay. C. 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 A. So I see a divergence here, though I think humble majority goes for C. Okay. Let's find out the right answer is localized hematoma and or hypovolemia cause tamponade without plethoric IVC. Okay. So this is really important, and this takes me to this important table here. So if we have, I'm gonna just take the pen here. My pointer is the pen. Okay. See that the large pericardial effusion with the swinging heart, we don't know about sensitivities and specificities for tamponade. Probably the same applies to the mitral and tricuspid inflow variation. But now the diastolic collapse of the right atrium, if we go qualitatively, present or absent, it has a wide range, but by and large, poor sensitivity and poor specificity, but tends to have a higher sensitivity. But if the same sign is timed to the cardiac cycle, RR interval, and it is more than 1/3 of RR interval, it becomes 90% sensitive and 100% specific, meaning it has a very good ability to rule in tamponade. Specificity bias in ruling in, sensitivity bias in ruling out. Now the diastolic collapse is here. Okay. For the plethoric IVC, which is defined as a dilatation more than 20 and less than 50% collapsibility, now the sensitivity is 97, meaning it has high sensitivity. So it's good to rule out, but not to rule in, okay? So if I take you back here, the state of IVC has low sensitivity. No, it has high sensitivity, but low specificity. So the highest specificity goes for RA collapse more than 1/3 of RR interval. And the highest sensitivity goes for plethoric IVC. Okay? Good. Now this is the RV collapse, as you see it here, and it is very difficult to time it to the RR interval precisely by eyeballing. So it's better to do M mode, and you see the inversion here and how much it occupies. And here is your ECG, and here is the duration of the collapse. So you can tell if it is more than 1/3 of RR interval, as simple as that. Okay, good. Now this is the RV collapse. Okay. One of the major features we look for when we study pericardial effusion or when we analyze pericardial effusion for tamponade physiology. And now here, if you take this one here, it's very hard to tell if you have collapse or not. So if I ask you which window is the best to discern the collapse, it is the parasternal long axis. Okay, it's not apical window, and of course it's not the subcostal window, because in the subcostal window you might erroneously generate collapse because of the movement and because of the redistribution of fluid. Okay, so the parasternal long axis, remember this. Here is M mode, and M mode, of course, can show it even better because it has the highest temporal resolution among the modalities of echo, 2D, 3D, Probler, and all of that. M mode is the highest temporal resolution, so it can detect the subtle wall excursion better than the 2D. Okay, so you can see it better. That's here is the diastolic collapse. And remember, you have to make sure, because some people we can do this one here. It goes this one, and it comes like this. So he think that this is the diastolic collapse. No, this is not diastolic collapse, because if you time this part, it goes in systole. And because in the RV goes in systole, that is normal. But it goes in diastole, that's abnormal, that's diastolic collapse. So make sure that you are checking a diastolic phase. And that is either by ECG down here or by aortic beside you, the closure of the aortic valve and the timing, okay? Now the plethoric IVC, yes, this is plethoric, can be very dilated, non-collapsible. Sometimes there might be even dense spontaneous contrast. Remember, to check for collapsibility, you have to have a little bit of long tracing, because it is respirophasic. It's not beat to beat, it is respirophasic. And when we say respirophasic, we are comparing, let's say, a heart rate of 80 with a respiratory rate of 16. That means you need like 5 cardiac cycle, okay, to pick up 1 respiratory cycle, okay? Good. So we have to have a longer tracing, because that is respirophasic. A longer tracing meaning is spanning about more than 5, and better to have 10 beats. Another finding of tamponade physiology in echo is the mitral and tricuspid inflow respirophasic variation. And of course, in tamponade, you will have the flow here of the mitral inflow decreasing with inspiration and increasing with expiration, and the opposite is here. So how much we take here at the threshold for significance, and how much we take in the tricuspid valve as significant. Here we take like 25% variation. Here we take 40% variation. So these are suggestive of tamponade if it is more than 25% variation and more than 40% variation. Okay, this echo equivalent, the echo equivalent of this hemodynamic tracing is which? That's the hemodynamic tracing here. And I want you to find out what is the echo equivalent of this hemodynamic tracing, A, B, C, or D. Go ahead and key your answers. A, A. My quorum is 5. I'm looking for 5 answers. Okay, so A, 4, and D, 1. Unfortunately, all who have voted got it wrong. The right answer is B. Why B? Okay, here is, this is pulsus paradoxus, right? Pulsus paradoxus is respirophasic changes. So during inspiration, the arterial pressure goes low and it goes up in expiration. Okay, and it's a sign of tamponade. It's a clinical sign of tamponade. Now, the echo equivalent of that is what? Is this one, LVOT, respirophasic flow. So if we follow the RVOT, we are seeing that during inspiration, which is here, the flow goes low. During expiration, it goes high. Inspiration, low. Expiration, high, and so on and so forth. Okay, good. So if we have tamponade physiology and we interrogate the LVOT, we are gonna find a respirophasic flow changes. So the flow decreases during inspiration and increases during expiration by more than 10%. Now this one here is the commonly mistaken sign This is called pulsus alternans, which is beat-to-beat variation, beat-to-beat variation, okay? That beat-to-beat variation indicates severe LV systolic dysfunction. And you can also have an echo equivalent of that. If you interrogate the LVOT, you are going to find beat-to-beat variation, beat-to-beat variation, okay? Small and large, small and large. If you look down at the ECG, will you find anything? No, because it's a common mistake to conflate pulsus alternans with electrical alternans, and they are totally different, okay? Pulsus alternans, something different. We are going to discuss that in a bit. If I take you back here, because I see the convergence is wide, here, what you are expecting to see is pulsus electrical alternans in a swinging heart. Now, this is pulsus paradoxus. This is pulsus alternans. But pulsus paradoxus sometimes can be severe enough as to stop the flow nearly altogether, and the aortic valve fails to open in systole, like in here. Like in here, this is inspiratory phase. And you see during inspiration, we missed probably this and this, okay? We missed opening of the valve here, and it opens just a little bit here because of the severe decreased flow during inspiration. And this is an extreme sign or extreme form of pulsus paradoxus, probably the patient in shock, okay? Now, this ECG of a patient with pericardial effusion, and the ECG shows complex to complex voltage variation, which indicates what? Pulsus alternans, pulsus paradoxus, like pericardial effusion, tamponade, pulsus deficit. Go ahead. This is what? A, C, E, C, E, A, C, E, A. Type C, E, A. Why this divergence? Divergence. It is. By the way, I'm so sorry here. Look here. I don't know if it's clear, but you are appreciating pulsus electrical alternance. Okay, so electrical alternance is not pulse alternance. So that is definitely wrong. Electrical alternance is not pulsus paradoxus. So a pulsus deficit is something different. Is when you check the pericardial pulse and the peripheral pulse, and they are different in atrial fibrillation and stuff like that. So we are between C and D. Is it tamponade or live pericardial effusion? The right answer is live pericardial effusion, okay? Because it all indicates is that we have a live pericardial effusion with a swinging heart, but it tells nothing about the actual compression. Though circumferentially, you might say it indicates tamponade because the larger the fluid, the more chance to have a compressive effect, but no, it just indicates large pericardial effusion. Okay, and the low voltage, we have to remember that the definition of low voltage is less than 5 millimeter in the limb leads and less than 10 in the pericardial lead, okay? And this low voltage is not only a sign of large pericardial effusion, but can also be pleural effusion if it's large enough to cover the heart, fat, obesity, COPD, infiltrative disorder, infiltrating the heart, and loss of viable myocardium in severe dilated cardiomyopathy and massive myocardial infarction. Word of caution, when you are interpreting for LVH, look at the right side for calibration and standardization. Make sure that it is set right. And this is the right calibration, 10 millimeters equals 10 millivolts. Because if we go down with it, we create low voltage. If we go higher with it, we create high voltage. So before interpreting the voltage, just have a quick glance on the calibration, make sure it's right. Also, it's important to differentiate between pleural effusion and precardial effusion, and your landmark here is the descending aorta. Lateral to the descending aorta and medial to it. Okay, so medial to it and lateral to it. And you see that the precardial effusion usually ends abruptly at the atrioventricular groove, but here it can extend all the way, embracing the descending aorta. Okay, and here is also a difficult case because is that precardial effusion or pleural effusion? If you see this mass, which is the lung, that is pleural effusion. Okay, so this is another tip-off to whether to pleural effusion. It isn't always easy to tell them apart, but the lung is going to help you really a lot. Sometimes you can see a hairy kind of precardial effusion. These are fibrinous strand, and this indicates kind of infection, blood, uremia. Okay, and so it points to certain type of diagnosis on one side and makes pericardiocentesis a bit of a hassle, because if you go in here, it is sometimes very difficult to rupture the loculated effusion between the septa. So full aspiration might be a problem. Also, you have to tell apart whether this is a fluid or fat. The fat has a different density than fluid, and it is not uncommon to mistake a pericardial effusion with pericardial or epicardial fat. Here is a pericardial effusion in CT, okay? And look here, it looks denser than this part, which is epicardial fat. This is epicardial fat, and this is pericardial fluid, okay? This is a patient has been admitted for a week for viral pneumonia and is recovering now with stable hemodynamics, no symptoms apart from fatigability. He is due for discharge next morning. What is the best course of action? So he's recovering from pneumonia, doing fine, is stable. His echo is showing this. So what do you think? Pericardiocentesis for diagnostic purposes, close clinical supervision regardless of the echo hemodynamics, therapeutic pericardiocentesis if echo hemodynamics suggests tamponade physiology, go with the discharge plan. Go ahead. Okay, all C. Oh, that's good. Good. Thank you so much. I'm so happy that you have chosen C, which is not only the right answer, but it's the actual wisdom as well. You see, because I expected some will choose this one, the B. Okay. As far as I don't have a clinical features of tamponade, I'm gonna wait and see. Watchful waiting. That is not categorically wrong. That's not categorically wrong. As far as the pericardial effusion is concerned, you can go proactive or reactive. Reactive meaning you wait for the shock to happen or the early signs of shock like tachycardia and hypotension, and then you act. In this case, you are running against time. But acting proactively meaning that the patient is still clinically stable, but you have an imaging evidence of tamponade or evolving process of tamponade, because tamponade is not all or none. I'm going to tell you something important about tamponade. If you look here, as the pericardial fluid increases, the intraprecardial pressure increases, and this will increase the RV filling pressure, okay? And it's going to increase the LV filling pressure. Now, when you look at the cardiac output, it goes down gradually, but it reaches a point, it goes so precipitously, and nobody can predict this point, okay? So that's the problem. See, it goes from this smooth going down and decline to plummeting so suddenly and abruptly. Here is the problem. That's why you better act proactively if you have an imaging evidence of tamponade. Sometimes even in the absence of imaging evidence, if it's large enough, it's better. Okay, and it's always important to know that it's not only the volume of the fluid, but the rate of accumulation of the fluid is so important, because the faster the fluid accumulates, the more likely it exceeds the reserve of precardial stretch and more likely to generate tamponade physiology. Of course, how you do pericardiocentesis, you have to say echo-guided pericardiocentesis, the safest, the easiest, and the most successful. Okay, echo-guided. Now, here is just, if you see, this is a pigtail catheter, and we are seeing a rim of radiolucency here. Okay, this is pericardial air, and here also is a large amount of pericardial air. Yeah, I'm seeing somebody who has answered pneumoprecardium. Yes, so this is pneumoprecardium, and you can see it in echo as bubbles in the precardial space. Fortunately, this is a rare disorder, but it can be encountered in condition like trauma, iatrogenic sometime. If you do pericardiocentesis, you might introduce air, and if there is fistulation between an air-bearing structure like esophagus and the pericardium, God forbid. And sometimes if you have an infection, gas-generating organism, it might also lead to that. The patient has cancer with mets to the heart. Which of the following is true? The mets will most likely be an intercavitary mass, i.e. it seeds to the endocardium. The metastasis has predilection to the pericardium. The metastasis will be complicated by transudative pericardial effusion. The metastases are most likely from a melanoma. Go ahead. C, B, D. Okay. A, B. Okay, so I see like kind of neutrality here. The right answer is metastasis has predilection to the pericardium. So if there is metastasis, they go to the pericardium in most of the cases. Sometimes they can go intramural and so rarely intracavitary. Okay. Now, this is metastasis, the surface of the heart. And if I ask you from where it comes from the most likely occurring tumors, which is bronchial cancer and breast. Now, what if these metastases are metastases from melanoma? Now, melanoma has a quite high predilection to seed in the on the surface of the heart. If it's present, but it is so rare tumor. So if I ask you about this is a trick, it's a bit of a catch. I want you to make sure you get it. So metastasis comes to the surface of the heart from common tumors. But if we have melanoma, it goes to the heart preferentially, okay, and it seeds with a high percentage. But it's not the common mets on the heart, given the total statistics about tumors, because it's a rare tumor, okay? The chest X-ray here shows hiatus hernia, artifact, pericardial calcification, pericardial cyst, raised hemidiaphragm. Go ahead. Okay. D. Okay. D. Very good. Very good. So that's a unanimous answer. And D, the right answer. And this is the typical location, the right cardiophrenic angle. Okay. The right cardiophrenic angle. You can see it in AAP or you can see it in lateral X-ray as well. And here it is. And here how you see it in CT. Okay. Usually it encroach, if it does, it encroach upon the right atrium. Okay. So here it is in the subcostal. You can see it in the subcostal, like here. Okay. Small one and a large one. As you see here, it's abutting on the RA. Here it is not compressing the RA. So the treatment is conditional whether or not it is compressive. Otherwise, it's a benign, most likely incidental finding. And here it is excised cyst in a patient of compressive precardial cyst. Okay. Okay. A 45-year-old gentleman presented with the following signs. So we have a hemodynamic sign and echo sign. So what is the next course of action? Send for surgery order cardiac CT, start the patient on a short course of steroids, follow up in 6 months. Go ahead. I'm waiting for you. Okay. Nobody has keyed her answer yet. Okay. Nobody? Bit confusing, huh? Say B. Okay, now I get the answers. B-A-A. A. Okay. Good. A, yeah. A isn't wrong, by the way, but I tell you something. Now, this is what? This is cosmal sign, right? You see the RA pressure increases during inspiration. It's supposed to decrease, okay? So increasing during inspiration defines cosmal sign. Now here what we have, that's the M mode of bouncing septum, bouncing septum. So it goes leftward in inspiration and it goes rightward during expiration. So having these two are enough to diagnose constrictive pericarditis. I'm going to tell you why. So I diagnose constrictive pericarditis. What shall I do next? Send for surgery right away, or order cardiac CT, or short steroids, or follow-up. So I see the majority has chosen A, but the right answer is cardiac CT. Why cardiac CT? Because cardiac CT, the surgeon usually need to know, okay, do we have, first of all, thick pericardium or not? Because I'm going to tell you that there are 18% of cases, they have normal thickness pericardium, though they have constriction. So are these patients going for pericardial stripping? You might need to think twice. The other thing is that the amount of calcification and how much it digs into the myocardium. These are all precious pieces of information you need to grasp for technical reasons before surgery. Okay, so cardiac CT, usually the investigation as a bridge before surgery or before surgery. It's an important part and parcel of the workup for constriction. If we have this 45-year-old, no past history of note, currently asymptomatic. He did this chest X-ray as part of employment checkup. His physical exam is unremarkable. What's the next step? Reassurance, echo, cardiac CT, follow-up, chest X-ray in 6 months. Okay. So, طيب, I see CT, B echo. I need 5 at least. C, cardiac CT, B. Okay, so 3 has chosen C, 2 has chosen B. Now here, look, that this MCQ is a bit different than that one. That one we have diagnosed constriction, okay, by the hemodynamic and echo. Then what shall we do next? CT, before surgery. Now here, we just have a pericardial calcification in the chest X-ray, eggshell calcification. So in this case, you cannot just go ahead with cardiac surgery, of course, and you cannot reassure the patient just like that. We need to look for evidence of constriction. Now, he is clinically fine, so there are no clinical features of constriction. But if there are clinical features of constriction by echo, this also is going to tilt the balance towards surgery or intervention if echo showed signs of constriction. Okay, so here we are going to do echo first to diagnose, because we did not yet diagnose constriction. You can have pericardial calcification without constriction, not by imaging, not clinically, not both. Okay, so you have to diagnose constriction first. Good. So here are the pericardial calcification. Of course, the pericardial calcification, you can see it even better in the lateral X-ray. Okay. Now, what about this calcification here that is not pericardial calcification? This is a pouching calcification. So this is calcification of aneurysmal apex. And when you look at the calcification here, this is the calcification of mitral annular calcification of MAC. Now, fluoroscopy can show the calcification really great. Like here, this is pericardial calcification. And here is, of course, arterial calcification or coronary calcification. Coronary calcification, you see it better without the dye. When the dye vanishes, you see the calcification. Even the stent, you see it better without the dye. Okay. Okay. Now, cardiac CT is important to tell us about this part, how thick the pericardium is. This is non-calcified pericardium, so they check the thickness. This is a calcified pericardium. Okay. What you see here, this density, this is epicardial fat. This is not the pericardium. The pericardium is this one. Okay. And here is the one which is calcified. Okay. A 55-year-old, previous history of CABG 5 years ago, not worsening dyspnea, exertion, pedal edema. On exam, he is noted to have elevated JVP that increases with inspiration and allowed early diastolic sound. He is most likely to have which one of the following? Mitral stenosis, ischemic cardiomyopathy, constrictive pericarditis, restrictive cardiomyopathy, post-cardiotomy syndrome. Go ahead. C. Okay, that's all. I suppose this is an easy one. Okay, I need 3. Yeah, constriction, good. Who else? Last, I'm waiting for you. C. Okay. So all of you agrees with this constriction. Constrictive pericarditis, yeah? Okay. So this is very characteristic, the Cosmol sign, increased JVP with inspiration, and loud early diastolic sound. This is loud S3 pericardial knock. That's the pericardial knock, okay? So this is constrictive pericarditis, and having CABG 5 years ago is a risk factor, okay? That brings us to the causes of constrictive pericarditis. The most common is still idiopathic, followed by cardiac surgery, okay? So the 2 most common causes worldwide are idiopathic and cardiac surgery. Radiation, renal failure, connective tissue disease, infection, tuberculosis comes last. Okay, so this is pericardial calcification. This is pericardial fibrosis and thickening. So it's not necessarily always to have calcification. You can just have thickening. The normal thickness is 2. If it is 4, that increases the chance of pericardial constriction. 6, high specificity of constriction. But remember, 18% of constriction turn out to have normal thick pericardium. So normal thick pericardium does not rule out constriction. Good. Now, 48-year-old gentleman has radiotherapy for mediastinal tumor 3 years ago. Presented with lower limb and abdominal swelling. Careful echo analysis revealed the following data. Apparently normal pericardium with no calcification. Septal bounce in 5 beats. Medial E prime velocity is 16 centimeter per second. Lateral E prime velocity is 10 centimeter per second. The patient was in AF, so hepatic reversal was not demonstrated. Ventricular contour is normal, mildly dilated atria. Based on the clinical and echo data, the best next course of action is order invasive hemodynamics to confirm constriction, order cardiac CT in preparation for surgical pericardial stripping, follow up with echo in 6 months, order X-ray, chest X-ray, AP and lateral, 4 weeks course of steroid and follow up for clinical and echo improvement. Go ahead. B. Okay. Okay, 5 Bs. Good. Okay, and that's the right answer because this patient is having radiotherapy, risk factor for constriction. Now he had edema and ascites. Okay, he had septal bounce. He had medial E prime faster than the lateral E prime. That's enough. That is constriction, cardiac CT, cardiac surgery. Okay, good. So this echo sign is exclusive for constrictive pericarditis. It is called annulus paradoxus. It leads to overestimation of the pulmonary capillary wedge pressure. Its validity is lost in atrial fibrillation. It shows as lateral wall decreases strain and strain rate. Okay, go ahead. B, 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 okay. A, somebody has chosen A. So B. Like, let's find out what's the right answer here. Okay, so it's A, not B, not A. So what is this sign? I'm going to show you. First of all, in constriction, the three most important features are here. One is this one, septal bounce, and increased or preserved medial annular velocity, and hepatic diastolic flow reversal. Now you can have other features like plethoric IVC, mitral flow, and tricuspid flow, respirophasic changes, septal shutter, thick or calcified pericardium, distorted contour of the ventricle. But if you have like two of here, like you have respiratory septal bounce with increased medial annular velocity, the specificity of the diagnosis of constriction is 91. If you add on that hepatic diastolic flow reversal, the specificity goes up to 97%. So in that patient, we have this one here. We have septal bounce and we have medial E velocity high. So 91 specificity, along with the clinical feature that even increase this percentage, okay? Good. Now here, if you look at here, this is an advanced case of constriction. You could appreciate the bounce, but in the bounce, you have to be careful. A bounce is not beat-to-beat variation, it's not beat-to-beat event, it's a respirophasic event. So you need to take time, 5 beats at least to demonstrate it, okay? Now we are seeing here that's kind of constriction of the chamber from outside. Usually, what we see in constriction is not this much of contoural disruption or geometrical distortion of the ventricle, but in advanced cases, you can see this one. Dilated atria. Now, when we come at the medial and lateral annular velocity, the medial is 15 and the lateral is 12. And that is opposite to the physiology. Physiologically, the velocity of the lateral E prime is faster than the medial E prime. But now, because we have a pericardium that limits the expansion or the excursion of the lateral segment, the medial segment goes into hyperkinetic or compensatory hyperkinesis to compensate for the stationary lateral velocity. And here it becomes faster than the lateral velocity. And this is paradoxical to the physiology. That's why some people think it is annulus paradoxus. But unfortunately, it's not annulus paradoxus. Now here, look at the septal bounce. You see the septal bounce here and also here. You have to wait for a few beats to see that the septum flashes left and right, okay? Now here is the septal bounce by M mode, and as I told you, M mode is better than 2D to demonstrate any wall excursion. Any wall excursion is demonstrable by M mode better than 2D because of the higher temporal resolution of the M mode. Now this is the annulus reversus, called annulus reversus. It's a specific sign of constriction. The medial E prime velocity higher than the lateral E prime velocity, which is opposite to the physiological pattern. Physiological pattern, the lateral is freer, so it is faster than the medial, which is hang in the cardiac skeleton. But in constriction, the opposite takes place. That is annulus reversus, not annulus paradoxus. What is annulus paradoxus? Annulus paradoxus, usually, we know that E over E prime correspond to pulmonary capillary wedge pressure. The higher the pulmonary capillary wedge pressure, the higher the E over E prime. But in constriction, we have the opposite relationship between E over E prime and pulmonary capillary wedge pressure. So the higher the capillary wedge pressure goes, okay, the lower E over E prime goes. It's opposite. This is the one called annulus paradoxus. Okay, so if you look here, normally without constriction, without constriction, E over E prime is directly proportional to the capillary wedge. The more capillary wedge goes, the more E over E prime, or the higher the E over E prime, the higher the wedge. But exactly the opposite here. The higher the wedge, the lower the E over E prime. Because as constriction advances, okay, it leads to higher LA pressure, higher pulmonary capillary wedge. But what it does lead to as well, it leads to faster E prime, faster E prime. So E prime here becomes high. So E over E prime is going to go low instead of going high. Okay? So the constriction increases the LA pressure, increases the pulmonary capillary wedge, but it also increases the medial E prime velocity. So E over E prime does not go high. In fact, it goes lower as the pulmonary capillary wedge pressure goes higher. So when do we need invasive hemodynamics? If echo does not sort out the diagnosis, which is quite unlikely. Now, if we have clinical and echo features, we go for treatment. Now, course of steroids and non-steroidal is just if it is transient, effusive constrictive pericarditis. But in cases of chronic constrictive pericarditis, like a patient post-CABG or post-surgery and 3 years and now presented with full-blown clinical features, stuff like that, that is chronic constrictive pericarditis. In this case, you proceed for surgery. Now, this is important hemodynamics. I think you acquaint yourself with quite well. This is the invasive hemodynamics. The main difference between constriction and restriction is this one. In constrictive pericarditis, there is discordance, meaning as LV goes high, like here, LV goes high, RV goes low. Here, LV goes low. I mean the pressures. LV pressure goes low, RV pressure goes high. And this is because of what? Because of the enhanced or exaggerated or augmented interventricular interdependence in constriction, which is not the case in cardiomyopathy. Okay? It's not the case in cardiomyopathy. Cardiomyopathy is still concordance. So in cardiomyopathy, there is concordance. In constrictive pericarditis, there is discordance. Okay, so the hallmark of constriction in invasive hemodynamics is the discordance. Good. Now, also, it's worth noting that the atrial enlargement is more pronounced in restriction than in constriction, and pro-PNB tends to be higher in restriction than constriction. Pulmonary artery systolic pressure tends to be higher in restriction than constriction, lacking the medial E prime velocity tends to be higher in constriction than restriction. Now, this is an important slide because these are 4 types of hepatic venous Doppler. And here it shows that if you follow the diastolic flow reversal, this is diastolic flow reversal, you just need inspiration and expiration. So in inspiration, it increases, in expiration, decreases. So this is a sign of restriction. Now, if you look here, during inspiration, it decreases. During expiration, it increases. That is constriction. So constriction, what is the sign of constriction in hepatic venous Doppler? Is increased or augmented or enhanced expiratory flow reversal during expiration, which is demonstrated here. Now, if I have a diastolic reversal that is fixed, that doesn't change with respirophasic, doesn't change with respiration, this is pulmonary hypertension. And of course, if you have, this is all about diastolic reversal. We have only one systolic reversal you need to know about, which is this one. When you have systolic reversal, that is severity R with a high positive predictive value. Good. Now, the hepatic Doppler is suggestive of constrictive pericarditis, restrictive cardiomyopathy, AV deassociation, tricuspid stenosis. Go ahead. Go ahead. Go ahead. No one. No one yet. Anybody? Guess. D, A, okay. DNA. Okay. C. DNA and C. طيب, okay. The C, the right answer. These are, if you look here, the ECGs, I think there is pacemaker, complete heart block, stuff like that. And this is diastolic reversal that comes and goes. It comes like very sharp spike, then we lose it, then it comes again, kind of irregular, stuff like that. This reminds you of what? Cannon wave of AV dissociation. Okay, so cannon wave impart itself in the hepatic venous Doppler like a spiky wave that comes intermittently and irregularly due to AV dissociation. So when the right atrium contracts against a closed tricuspid valve, we get this spike. Okay, we get this spike. Good. Now I have 45-year-old man presented with chest pain and found to have ST changes of ischemia. He also admitted to having syncope 3 times over a period of 1 year. Coronary angiogram showed normal coronaries with only slow filling. Echo was ordered before the cath and showed normal regional wall motion. I wouldn't say normal regional wall motion abnormality, normal motion or no segmental wall motion abnormality. But the formal report later added that there is a small mass on the aortic valve which needed TEE for further clarification. What is true about this patient's condition? So chest pain, syncope, echo is normal apart from a small mass in the aortic valve. So slow filling is the likely cause of his syncope. You will order SPECT to define more accurately for provocable ischemia. The man most likely have infective endocarditis. The mass is fibrolastoma, and it's the cause of transient ischemia and syncope. TE will most likely reveal degenerative changes at the AV with missed severe aortic stenosis. Go ahead. 4, 4, 4, 4. Very good. Very good. So simplicity is the ultimate sophistication. In MCQs as well as in all clinical problems, you better be simple, okay? That does not mean you really not have to be sophisticated sometimes, but simplicity is important too. Now we have chest pain, we have syncope, and we have an aortic mass. So I'm going to take these 3 and try to find a unified diagnosis, which is here. Some people might think more complicatedly and think of ruling out ischemia. That is not categorically wrong, but if I have a mass, I would assume a cause and effect relationship. Okay, most likely this is a fibroelastoma. Okay, and this is fibrolastoma. You know, what is characteristic about fibrolastoma is that when you impregnate it on a normal saline, it fans out like sea animal. And it is most commonly found on the aortic valve, and it has a stalk. So there is a stalk and a ball like this, okay? So this is the characteristic morphology of fibrolastoma. By the way, fibrolastoma is the most common valvular tumor and the second most common benign tumor. The most common benign valvular tumor and the second most common benign tumor after myxoma. Okay, so you really have to know about it. That brings us to this, and this is really important here. Just see here. The most common benign tumor of the heart is myxoma. And the most common malignant tumor usually is metastasis. But primary cardiac tumor, the most common primary malignant cardiac tumor is angiosarcoma. Okay, so here is myxoma, and you know a lot about myxoma. For papillary fibroelastoma, we discussed it now. most commonly on the aortic valve, but it can also be found on mitral, pulmonary tricuspid, yeah? And you have to take it out if it is large or it's causing symptoms. Rhabdomyoma is a tumor of childhood, and usually it regresses over time, so you don't have to do anything about it unless it is obstructive or arrhythmogenic. Fibroma, yeah, it's one of the tumor that you might encounter. It's on the lateral posterior wall, and it is arrhythmogenic as well as it can be obstructive, so it has to come out. Now, angiosarcoma is the malignant tumor of the heart, and it usually has a predilection to the right atrium and AV groove. It is very invasive, very poor prognosis, and all of that. So that's what we have to know for now. This is fibroma, as you see it here in the posterior wall, fibroma. It can be obstructive, but more commonly, it is arrhythmogenic. Myxoma, nobody can miss it. And here is the angiosarcoma, which is the most common primary malignancy of the heart. Okay? And usually we go for palliative therapy. Nothing is going to help. Okay? Which of the following is the stochastic effect of radiation? Nausea and vomiting, plastic anemia, cataract, skin burn, cancer. Go ahead. This is one of the meanest MCQs. 5. Cancer. Okay. 5. Good. Yeah. Because this is one of the things that is hard to guess. Either you know or you don't know. Okay. Stochastic effect. The right answer is cancer. So here there are two types of effect for radiation. Okay. One is here. Oh, I'm missing this one. So it deterministic effect, and as the name implies, it is kind of inevitable. Inevitable meaning if you reach a threshold of radiation, you are bound to have kind of an effect. But a stochastic effect is cumulative effect. It has no threshold. But as you go higher with radiation over a longer period, the chance of getting that increases. That's cancer, right? But deterministic effects are threshold related effects of radiation. So if I exceed a certain amount of millisievert, I'm bound to induce, okay, certain effects. And this is like hair loss, cataract, skin injury, erythema, ulceration, okay? These are deterministic effects. So the stochastic effect of radiation is cancer. 70-year-old male, 6 months post-TAVI, admits to appreciating no improvement in his symptoms of shortness of breath. Recently, he stops valsartan and amlodipine he used to take for blood pressure because of postural dizziness and home readings documenting low blood pressure. Echo revealed ejection fraction of 45 with mild global hypokinesis, which was normal before TAVI. Well-seated TAVI processes, no paravalvular leak, mean gradient is 14. Has moderate LVH. Septal thickness is 1.5, which was present before TAVI. Has grade 3 diastolic dysfunction. ECG normal voltage with normal sinus rhythm. What is the next most appropriate step? Investigate for ischemic cardiomyopathy with a view to revascularization. Introduce an uptitrate atenolol 100 to treat diastolic dysfunction. Investigate for amyloid, coronary angiogram, reintroduce his antihypertensive at a smaller dose, and follow up. So go ahead. Okay. C. Okay, C. Giving you more time here. So I want to enjoy your answers, which are all C so far. Okay. C. Nobody's going to investigate for ischemia. Okay, good. Okay, so the right answer is investigate for amyloid. So what are the tip of to amyloid here are post-TAVI, intolerance to antihypertensive, and LVH. Okay, That's all. And 70-year-old male. Okay, that's right. So screening for TAVI, or when do you initiate the workup for, when do you initiate the workup for amyloid? Is when you have ventricular thickness more than 1.2 centimeter plus one or more of heart failure, especially HFpEF, more than 65. Aortic stenosis, pre or post TAVI, in a patient older than 65. Hypotension or normally treated hypertension. Sensory involvement, autonomic dysfunction, peripheral neuropathy, proteinuria, skin bruising, bilateral carpal tunnel syndrome, rupture biceps tendon, and MRI. There are MRI feature, which is transmural late gadolinium hyperenhancement subendocardial, global subendocardial, apically sparing strain in echo, decreased QRS voltage relative to the mass, and other. Now here, look, ECG was normal voltage, but you still have been courageous not to distract you from the diagnosis of amyloid. And this is important. So now we know when to initiate workup for amyloidosis. But of course, in amyloidosis, you have LVH. Don't mind the sparkling texture. This is kind of subjective. You can have a small rim of pericardial effusion. Importantly, to measure the RVH, because if there is RVH as defined as RV wall more than 0.5 centimeter, that adds to the probability of infective endocarditis. Okay. There is also thick valve and thick interatrial septum. Now, when we come to the ECG, we always look for the low voltage. But the low voltage, the presence of low voltage ranges from 20 to 74 across the entire spectrum of the literature that studied this. So it doesn't mean a lot. It does not rule out if you don't have low voltage, okay? Does not rule it out. And that's why now people suggest to go by the mass voltage ratio, meaning you take the mass as seen in echo, okay, and the ECG, the voltage, okay, the ECG. Because what happens here is, if you have amyloid, I have very large mass, but the ECG is normal voltage. Normal voltage for a robust mass is low voltage. So don't always look for low voltage. Low voltage isn't common, and it indicates very advanced cases. So now we look for the ratio between the mass and the ECG. Good. Of course, when you are asked about the gold standard for diagnosis, it is PET scan. And here it is uptake. We look for the heart uptake. Here it's 0, no uptake. Here it's grade 1, less than the bone. It's grade 2, as equal as the bone. Here it's more than the bone. So this is amyloid for sure. And here it is also high suspicion of amyloid, but here is not, okay? So things that you have to remember about amyloid: if patient is on AF, you initiate anticoagulation regardless of CHA2DS2-VASc score. Beta blocker you should deprescribe because of the possibility of inducing blocks. Avoid ACE and ARBs because of hypotension. Use digoxin cautiously. These are important points. 32-year-old lady complains of 3 days dyspnea at rest and dizziness, no past history of note. Cold, clammy extremities, fast and feeble pulse, blood pressure 65/40, bilateral crackles up to the mid-zone, ECG features of LVH, sinus tachycardia, echo EF is 20%, global with mild mitral and tricuspid regurg, a small secondum type ASD. Based on this data and cardiac biopsy, diagnosis of giant cell myocarditis established. The patient is hooked on steroid, IV immunoglobulin along with inotropic support. The team considered LVAD for mechanical support. Which of the following is true? So, LVAD, which of the following is true? LVAD is not indicated as it's a bridge to recovery and the prognosis of giant cell myocarditis is poor. ASD is contraindication to LVAD. LVAD is not indicated as a bridge to transplant. Immunosuppressive therapy should be considered before LVAD. LVAD is indicated as a bridge to recovery or transplant. Go ahead. Go ahead. E, 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 E. Okay. E, by the way, it isn't wrong, but I tell you something here. Okay. So you have chosen this one. And I expected some of you to choose this one. ASD is contraindication to LVAD. Type. The LVAD, you know, it's an inflow and outflow and a pump. Okay? Three main components. Inflow cannula, outflow cannula, and the pump. So it's kind of bypassing the left atrium. Okay? So it's a bridge to transplant or to recovery, or it can be destination therapy. The contraindication are here: irreversible in organ damage, metastatic cancer, cerebral damage, coagulation disorder, bleeding disorder, mechanical valve, and severe AR. So ASD isn't there, although ASD is problematic, because if you have an ASD here that takes blood usually left, right, and now you are doing suctioning here, so you are decreasing the pressure, that might reverse and it become right, left, and the patient end having resistant hypoxemia, but it is not contraindication, okay? Now, it is so important in echo, we keep following certain things: LVRV function and septal position. Septal position. The septal position has to be central. So if it bows leftward, meaning that you are overdoing it here, okay? You have to slow down. So septal position is important. Inflow cannula position and velocity is important, okay? Because if it kinks on the wall, its efficacy wouldn't be as expected, okay? And the aortic valve opening is also important because that tells us about how frequent the device is working, and we keep it like a ratio, how many times it opens per 10 beats. We usually keep the valve opening intermittently every 5-10 beats just to eliminate the chance of thrombosis on the valve, because if it stays still, it might become thrombotic. And AI severity, AR, because the device itself induces AR, because you are pumping blood just above the valve. That might lead to problem in the integrity of the aortic valve, and it can leak, okay? So severe AR to start with is contraindication, because what you are doing is, if you are filling in the aorta and it goes all back because of AR, you are doing nothing. Okay, which of the following is the role of all cardiac markers? TNC, troponin C, troponin I, troponin T, BMP, CA125, or troponin T, troponin I, BMP, CA125, troponin T, troponin I, BMP, troponin T, troponin I, troponin C, PMP, troponin T, troponin C, PMP. Go ahead. E, E, good, E. Okay. So I see all of you has chosen E, which is the second right answer, but not the first right answer. This one, yeah. I think, sorry, you have chosen E. E, just a moment. Have you chosen E or something else? Oh, sorry, C. You have chosen C. I'm sorry. C, which is this one, which is the second right answer. This one is not right. Anything that has C, troponin C, is not cardio-specific. It's only I and T. So this is out and this is out. So we are left between this one and this one. And I see that you have excluded CA125, which is a cardiac marker. So CA125 is a marker of congestion. Okay, remember that. It's a marker of congestion. And now it is incorporated in clinical practice. Okay. I wouldn't go further with that. I will leave it for this. And it's even prognostic in terms of mortality, hospitalization, heart failure, and all of that. Now we come to the pre-op assessment. It's important about pre-op assessment is to know that it's better to be done as close to surgery as possible. So if you do it like in a clinic, okay, like 3-5 months before surgery, that might not integrate with the surgery or the clinical status of the patient just before surgery. It's important in your analysis for the pre-op is to encompass different, different features. One is patient relating features, the nature of surgery, and the timing of surgery. Okay, so these are the three main components you incorporate in your analysis to decide how to proceed further. Now, proceeding further is what? Is either you ask to postpone surgery, or you do ECG, markers, echo, stress testing, coronary angiogram, or sometimes you request valve surgery or intervention. So this is the scope or the landscape of the pre-op assessment. Now, it's important here, we know that we have patient-relating risk and we have a scoring system in place, and we have surgery-related risk. And that divides surgery into low-risk surgery, intermediate-risk surgery, and high-risk surgery. And unfortunately, you have to acquaint yourself with this, okay? Because it's so important to know what is the nature of surgery in terms of its cardiac risk. And the timing of surgery, immediate or emergency, urgent, time-sensitive. Time-sensitive is still, we need to do stuff within a limited frame of time. Elective, we have good time to discuss. I have this 55-year-old lady, diabetic hypertensive, going for elective left breast lumpectomy. On clinical evaluation, the patient has poor functional capacity, but asymptomatic at rest. What is the best course of action? Go ahead. C, oh, sorry, D, and D. By the way, for the sake of pragmatism, if you find any pre-op assessment MCQs, proceed without further testing is the most likely answer. Okay, so proceed without further testing. Okay, لاحظ this patient is asymptomatic. She had poor functional capacity and everything, but proceed. Like, okay. So if a patient is low risk surgery, you proceed regardless of the clinical vignette. Meaning, whatever the clinical scenario is, if the surgery is low risk, you proceed. Like here, okay? Here, if surgery is low risk surgery, and low risk surgery, you proceed. If the patient is young, no risk factor. If old, with risk factor. If established coronary artery disease, you proceed. Now, for intermediate or high risk surgery, plus age more than 65, or cardiovascular risk, or established cardiovascular disease, you need to request ECG, biomarkers, and do functional capacity assessment. Okay, good. Now, when do we ask for T? By the way, in the guidelines is so frugal and cost conscious. So it's not like us defensive, we can order whatever. No, and for the sake of the exam, we go by the guidelines, okay? Now, T is recommended for certain set of scenarios, like here, poor functional capacity or hyper-PMP with high-risk surgery. Stress testing is recommended, high-risk surgery, poor functional capacity. So I summarize this in an easy way. I'm going to show you now. History, exam, and risk scoring and optimizing medication and hypertension, diabetes are all class 1 indication before surgery. Now, if I have a patient with angina, current angina, I have to do diagnostic workup before surgery, regardless of the nature of surgery. Okay? But if the surgery is needed acutely, I mean, it is either time sensitive or urgent, I go for multidisciplinary assessment. Now, if a patient is having dyspnea and or edema and no non-cardiac explanation for that, you do ECG and pro-PMB. Then if the pro-PMB is elevated, you go for TE. See where TE comes? Even if the patient is dyspneic and has peripheral edema and no non-cardiac explanation for that, you don't go for echo right away. You request ECG and pro-PMB, PMB. If it is elevated, then you go for echo. So echo is requested in these scenarios. One, here, sorry, poor functional capacity and high-risk surgery, or high pro-PMB and high-risk surgery, murmur and high-risk surgery, dyspnea and or edema and high pro-PMB. That's for echo. For stress testing, you have to have poor functional capacity, high-risk surgery, high clinical risk, or previous PCI or CABG, or current symptoms of angina. Coronary angiogram, there is no prophylactic intervention on its own merit. And you don't order coronary angiogram unless you are going to do that, regardless of the urgency of surgery. Okay, don't let surgery haunt your decision making. So, is this patient needs coronary angiogram? For the indication of coronary angiogram, go ahead. If not, don't. Okay, no prophylactic. Now for beta blocker, if patient on beta blocker, you continue. If patient on statin, you continue. And initiating statin preoperatively is class 2A, and initiating beta blocker in high-risk surgery to decrease the risk is class 2B. I have 62-year-old lady going for thyroidectomy for multinodular goiter. She is asymptomatic, but on clinical exam found to have murmur. Echo showed severe aortic stenosis with ejection fraction of 65. What is the best course of action? A bit tricky. Delay non-cardiac surgery pending surgical AVR. Proceed without further workup or action. Delay non-cardiac surgery pending TAVI. Coronary angiogram, stress testing to evaluate for symptoms. Go ahead. I get one E. 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 Okay. And the right answer is proceed without further workup or action. طبعا لاحظ هنا, I know that you get so alarmed with this severe aortic stenosis, okay, and going for thyroidectomy. Okay, let's find out. Now, if I have a patient of severe aortic stenosis, first of all, I'm going to judge upon the case by whether or not the patient has symptoms, okay? If no symptoms, then I'm going to look for the ejection fraction. If asymptomatic, a normal ejection fraction, proceed, okay? Proceed. That's it. Now, if he is symptomatic and or has low ejection fraction, you have to go for further assessment and further, kind of deliberation. Probably you might need to do TAVI or surgery before. It depends. Okay? But it's important, though it is severe aortic stenosis, it is asymptomatic with normal ejection fraction, proceed. Now, if I have severe AR, asymptomatic, ejection and systolic dimension more than 50 and all of that, or resting ejection fraction lower, valve surgery is recommended prior to elective, intermediate, or high surgery. And this reminds you of what? Of the exact indication, the conventional indication for AR, asymptomatic with low ejection fraction and dimensions and all. Okay. Now, in moderate to severe mitral stenosis and symptoms or pulmonary artery systolic pressure more than 50, valve surgery before elective intermediate or high-risk surgery. Okay, good. Again, even if you have symptomatic with indication for valve intervention, you go for valve intervention before, and this means, again, we are conforming to the conventional indication. So we are not swaying the indication because we have surgery on board. No, we are still committed to the guidelines for valve. Now, you wonder probably to ask, if I have severe asymptomatic AR and low ejection fraction, I'm going for low risk surgery. Or I have moderate to severe AS, symptomatic, pulmonary artery systolic pressure more than 50, and going for low risk surgery. You'll probably proceed. So we're talking here about intermediate and high risk, okay? Surgery. Now, when we come to the nuclear, I wish in diamond and nuclear, you look at it in terms of the mapping, okay? The perfusion map. This is the short axis. This is the horizontal long axis, and this is the vertical long axis. So what shows in here is the anterior, lateral, inferior, and septum. What shows here is the septum, apical, and lateral. What shows here is the anterior, apical, and inferior. And usually, by convention, stress is up, rest is below. Even if we don't have labeling, you go for stress rest, unless they reverse it, okay? So it's important to look at the perfusion map to tell about if you have perfusion defect, how many perfusion defects you have, the location of each, and the extent. Extent is mild perfusion defect, moderate, large. Usually the software is going to help a lot. In the exam, you probably have to go qualitatively, not quantitatively. It's also important they check the ejection fraction before and after stress, and this is software related stuff. Always look for transient ischemic dilatation and RV uptake, because the trick might lies here. Okay? Now, what best describe the SPECT images of this patient? Normal finding with alignment artifact, dilated RV, high ischemic burden, normal LV perfusion pattern. So what do you think? B, 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 B. Good. So all B, and unfortunately, you're all mistaken, is high ischemic burden. Because, you know, see, this is the normal RV contour. It's not dilated. That's how it looks like in nuclear. But the question is, why do we see it? We're not supposed to see the RV, especially that pronouncedly. It is so pronounced. And also, if you focus, you look at the cavity here, compared to the cavity here, you have an impression of dilatation, stress-induced dilatation. So I have RV uptake and stress-induced dilatation. These are features of high ischemic burden. SPECT images are most consistent with, now look here, ischemic cardiomyopathy, stress-induced cardiomyopathy, dilated cardiomyopathy, reconstruction artifact. Go ahead. See. Okay, good. So you have chosen C, and C is the right answer. Look here, the ventricle is dilated and probably dilated equally in systole and diastole, and there is no clear perfusion defects, okay, to account for this LV dilatation. So this is a picture of dilated cardiomyopathy. Now, what is the most likely diagnosis about this 55-year-old female with shortness of breath class 3? She is likely to have primary pulmonary hypertension, significant multivessel disease, severe left main disease, HFpEF. Go ahead. A. Who else? B. C. Okay, so a bit of divergence here. And the right answer is she's probably, she's likely to have primary pulmonary hypertension. Why? What we are seeing here is what? We're seeing first RV uptake, increased RV uptake. And probably it's increased equally in stress and rest. And we also have flat septum, which is D-shaped LV, Okay, so if we have this feature, that is not a real feature of ischemia as much as it is of RV problem. That RV is hypertrophied. Because if the RV is hypertrophied, it is start to shine through. Why it doesn't shine through? Because the pixels of radioactivity of the LV dims the RV. But the RV now gains its personality back because it's hypertrophied, so it shines through. So RV shines through if it's hypertrophied because of pulmonary hypertension, and because it shines through if the LV is very weak because of ischemia. So if the LV is ischemic, the RV also shines through. Okay? But the picture that the RV is equally shining in stress and rest goes for hypertrophy more than ischemia, because in ischemia expected to be more in stress. And also the D-shaped septum or the D-shaped LV goes more with hypertension. So here I'm going to show you this. Look here. Look at the RV. Stress, rest. So we are seeing it in stress more than in rest. Okay? So this is more of ischemia. While here I'm going to see the RV in stress and rest equally with a clear flat septum. This is pulmonary hypertension. Now, what do you think about this? Here, you see there is inferior perfusion defects. Inferior perfusion defects. You might also feel that there is TID. And TID, any increase between the volume in stress and rest more than 1.2. So globally, I mean, by eyeballing you can guess it, but they have software to assess it. Okay. So see here the inferior, also here the inferior hypoperfusion defects and the TID. Okay. So this indicates RCA with possible multivessel. Here is the anterior perfusion defects and apical. You see, anterior and apical. Okay, multiple perfusion defects. You might also feel that there is TID. Here there is inferior. And what else? Look at the inferior wall. And also look at the septum. Okay, so we know where the perfusion defects are. Here, apparently no perfusion defects, but if you focus, you will see the cavity dilates in stress. So this is TID. Here, no clear perfusion defects, but there is increased RV uptake and also dilatation, stress-induced dilatation. So this is high ischemic burden. Balanced ischemia, probably 3-vessel disease or left main. The stress and rest-prone SPECT images are most suggestive of what here? Severe ischemia, Hookham artifact, or severe MR? Go ahead. Yeah, and I brought this in particular because I want to familiarize you with the gray scale. So not always the bright colors and the nice colors. So here also you can appreciate no clear perfusion defects, but there is cavity change in stress and rest. You can compare it in here and here or here and here. So this is severe ischemia. Okay, now when we come to viability testing, by echo, we go for the hibernating myocardium, and we demonstrate that at low dose, we get contractility. At high dose, we lose it. This is called the biphasic response. And this indicates that there is a contractile reserve in the heart, meaning it's viable. Now, what is the best nuclear study for viability is not SPECT, it's PET. So in PET, they do perfusion map and metabolism map using rubidium or ammonium, here using FDG, fluorodeoxyglucose. And what they see is if you have perfusion defects that fills in with metabolism, meaning I have perfusion defects, but it is metabolically active, this is called perfusion metabolism mismatch, because I have no perfusion, but I have metabolism. This indicates what? Viability. But if I have no perfusion and it remains metabolically inactive, this is perfusion metabolism match, and this is non-viable. Now, the gold standard of viability testing, if available, is the MRI. And for the MRI, they go for the delayed hyperenhancement and how much it involves of the wall thickness, okay? So if anything more than 50%, that is non-viable. Less than that is viable, okay? So as easy as that, okay? Okay, I'm going to skip this one. Now for the aortic diseases, we really have to know that we have acute aortic syndrome. And acute aortic syndrome, we mean aortic dissection, intramural hematoma, and penetrating ulcer. Okay? These are the three acute aortic syndrome. And the classification, the DPK classification, which is not so practical and pragmatic, we go by Stanford classification. Even the guidelines goes for Stanford, which is type A, if it involves the ascending, and any others, type B, which involve the descending and not the ascending, okay? Now, it's important to know the mechanism of hypoperfusion and branch occlusion. It can be because of the thrombus here, or because of the flap itself, or because of the thrombus and the flap. The dissection flap can propagate in antegrade or retrograde fashion, and it leads to a life-threatening complication like AR, ischemia, tamponade, stroke, malperfusion syndromes. Propagation, if you demonstrate propagation itself, is an indication for surgery, whichever the type of dissection is, type A or B. If type B, the surgery is conditional to certain set of risk factors, one of which is propagation. Now, if you have, and this is a common source of questioning, if you have an AR or MI or tamponade, what are you going to do? Don't touch the patient in OR. Take the patient to surgery. So if you have tamponade, don't spare it. No. If you have MI, don't revascularize by coronary angiogram. Okay? So everything should go for OR. Here is, you see the flap. It's going retrogradely, interfering with the occlusion of the aortic valve. Here is the flap dilating the aorta and leading to malcoaptation and severe AR. And here is the flap in the descending aorta and no flap in the ascending aorta. So this is type B. Now, for type A surgery, we know that, common sense. For type B, uncomplicated medical therapy. If it's complicated, surgery. So what are the complications of type B? Rupture, branch occlusion and malperfusion, or extension, propagation, enlargement of the aorta, pain, or uncontrolled hypertension. Okay? Now, if we are dealing with penetrated aortic ulcer, what are we going to do? For penetrated aortic ulcer, we are a bit conservative. If there is rupture, okay, or intramural hematoma, you go for surgery. Now, for intramural hematoma, you deal with it exactly like dissection. If it is type A, go for surgery. If it is type B, go for surgery if it is complicated. And by complicated, we mean malperfusion, hematoma, cardiac tamponade, pain, or rupture. Okay? Now, for the aortic dimensions and aortic aneurysm, and when you operate, the timing for operation, which is the source of confusion because we have figure and our mentality is always hard to stuff in figures. Now, for HTAD means hereditary aortic diseases, okay? For hereditary aortic diseases, 5 on its own merits, 4.5 if risk factors. What do you mean by on its own merits? Meaning 5 indicates surgery per se, but 4.5 is conditional to having risk factors, okay? So what these are the HTADs which are very difficult to pronounce, one of which is Marfan syndrome, okay? But the high-risk feature I want you to know so well about are here. Family history of aortic dissection at aortic diameter less than 5. Family history of unexplained sudden cardiac death at the age lower than 50. Rapid aortic growth as defined by more than 0.5 centimeter in 1 year or more than 0.3 per year in 2 consecutive years. These are the risk factors. So I'm going to go back. 5 on its own merit, 4.5 if they are risk factors for HTAT. Okay. Now for Marfan. For Marfan, beta blocker and or ARBs are indicated as here. Okay, so they are class 1 indication. And this is gonna retard the progression of aortopathy. Now 5 on its own merits and 4.5 if risk factors or before pregnancy. Good? That's what you have to. Good. Now for bicuspid aortic valve. 5.5 on its own merits, 4.5 if going for surgery for the aortic valve, 5 if there's risk factors, low surgical risk, experienced surgeon, multidisciplinary aortic team. So we have a confusing figures here. For Marfan, 5 on its own merits, 4.5 if risk factor or pregnancy. HTAT, 5 and 4.5, like each other. So these are kind of similar. Now for bicuspid, 5.5 on its own merits, 5 if going for, 5 if high risk, 4.5 if going for therapy. Okay, good. Now I come to the last part. I'm gonna go quickly. Now for of course, coronary angiogram, I cannot go through it as much as is needed because I'm left with like 15 minutes. So I'm gonna just tell you some few stuff. I wish so well that you are so acquainted with the views and how you get the view and the naming of the branches and the lesion, how you describe it, and the ancillary finding. Okay, here it's important. You know the persona of the stent, how it looks like, the stent, how it looks like. Okay, the thrombus, the fresh thrombus, and the haziness it imparts, the calcification and how you see them when the contrast vanishes, the collaterals, don't forget about the coronary calcification and the non-coronary calcification, like the MAC and aortic calcification and the pericardial calcification. These are really important. And the art of the exam usually gives a kind of a load to the ancillary findings, because they want to make sure that you are a good observer. So don't get like distracted by, like that is called self-satisfying bias. When you find the major abnormality, you stick in there and forget to see any further. So look broadly and try to grasp as many of ancillary findings as possible. Okay. Now, this is the LAO caudal of the left system, and you see here, this is the left main. This is the LAD. This is going to be the diagonal. This one is coming right from the middle here, so it's probably ramus, or it can be high OM. This is OM, and this is the SEER proper. Okay. Now, here is the RCA, RAO. Now you see the RCA here. Now the branches are, this is the conus branch, and the conus branch usually follows the RV branch. And this is the SA nodal branch. This is RV branch, acute marginal branch. What's the difference between RV branch and marginal? They are both marginal, but the RV branch tends to be the stouter and the bigger. Now we came to the problem of figuring out which is PDA, which is a PLA. If you look, whatever has septal branches like this comb appearance, this is the PDA. And usually the PDA tends to be the lowermost, but you really have to appreciate the septal branches. Okay. Now here is epicranial view, and here is the left main, here is the LAD. Okay, now these are septal perforators. Here are diagonal. This is diagonal, diagonal, and probably this is also diagonal. And here is the circ. Okay, and there is moderate discrete lesion proximal. Now this is a iliocranial, and this is the left main. The circ is here, the OM is here, and this is LAD, diagonal, large one, and these are the septal perforators. Okay, I think I stop here. Okay, because I don't want to. These are like 2 hours, and I know that I get you so bored, and I'm so sorry for that. But I have to cover as many as possible. And forgive me if I go faster in the last section, and I'm willing to answer your question if any. I think you are all muted, right? Thank you. Thank you so much. Wish you all the best.